So this morning we're going to talk about transcatheter aortic valve replacement. Will surgical aortic valve replacement disappear? So I do have some conflicts of interest. As Alan said, I serve on a number of steering committees and I serve as national PI for a number of the trials, but I really don't think that's going to play into what we talk about here. The agenda for today is let's talk about, why is TAVR important, transcatheter aortic valve replacement? Where are we now and how do we get here with TAVR? And where are we going with TAVR, and will surgical valves disappear? And if I get fast enough, if we have any time, we'll do a little bonus thing on mitral valves, which we're starting. So this is a normal aortic valve. It's a tri-leaflet, very thin, very strong. It works amazingly well. You're looking at it from the aortic side on the left and the ventricular side on the right. The aortic valve sits right in the middle of the heart, right in the middle of the fibrous septum of the heart, and the mitral and the tricuspid valves are literally attached to it. Now, the aortic valve can go bad in a number of ways, and it can either become stenotic or narrow down or become insufficient and leak. And we're going to be talking today mainly about stenosis. And there are three big reasons that aortic valves get stenotic. You can be born with a bicuspid valve, two cusp instead of three, and those are never normal because they can never open normally. Why? Because you want your valve to open up the circumference of a circle. The circumference of a circle are 2 pi r. So that's basically 6r. So for a tri-leaflet, you have RR, 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 6R, but for a bicuspid, you just have RR, RR. A bicuspid valve can only open up to 4R. They're never normal, and what happens is abnormal flows leads them to calcify. Or you can get rheumatic heart disease, and you get an inflammatory fusion of your commissures, or what we're going to mainly talk about today is this degenerative calcific aortic stenosis. Your valve just wears out and calcifies. And what happens is calcium starts implanting in the valve, and over a period of time, it goes from just being a lipid deposition to actually calcium. Now, why is that important? This is anybody that deals with aortic valve disease has seen this slide 10 zillion times. This comes from an article by Ross and Brunwald back in 1968, and what they looked at was people with severe aortic stenosis and what happened to them. And they did okay till they got symptoms. And when you got symptoms, you died. And in fact, you died at a pretty rapid rate. You died at a rate worse than most cancers. And there was no medical therapy for this. It's a mechanical problem. I used to always tell my patients, like going in the backyard and turning on your hose and putting your thumb over the hose. The more you cover it up, the more pressure behind your thumb. And there's only two ways to make that pressure go away. One is to take your thumb off the hose. That's pretty good. The other one is to turn the water off. Well, that's not really good in people. Now, the problem is that if you have severe symptomatic aortic stenosis, you should have an operation or you're going to die. So people went back and looked at some big academic medical centers and looked through their echoes labs and said, how many people have severe aortic stenosis and how many go to surgery and how many don't? And the problem was about 30 to 60% of people with severe symptomatic aortic stenosis never went to surgery. Well, why would that be? Well, that's because a lot of them are older and people say, well, they're older, getting ready to die anyway. Let's leave them alone. And they had comorbidities. They were just thought to be too sick for surgery and they were just left to die because we had nothing really to offer them. But we're compassionate people as surgeons and cardiologists, so we put balloons in everything else. So somebody said, let's put a balloon in the aortic valve. We were part of these trials in the 1980s. I remember them very well. And you could blow up the balloon and you'd basically double the opening and half the gradient. The problem is it always came back. And they died at the same rate as if you did nothing. So that was eventually abandoned. And along came a guy named Henning Anderson from Belgium, and Henning said, well, listen, we're putting stents in things too. Why don't we put a stent in to keep the valve open to maintain the good early part of the balloon aortic valvuloplasty, but then put a valve inside of that? And Henning took it to his medical college, and they said, you're crazy, you can't do this. And so he actually worked with one of the surgeons, and at night they bought some pigs and kind of did this on the sly. And those are actually sternal wires from heart surgery that he's bent into a stent, and he's sewn a valve on there, and he put it in pigs. And it actually worked. So he tried to get it published in the Journal of American Cardiology, and they said, listen, this is no good, we're not going to publish it. Tried to send it to circulation, they said, you're crazy, we're not going to publish this. Finally, he got a poster at the European Society of Cardiology, but you see he's standing there all by himself, nobody really cared about it. It was like everybody thought he was crazy. What he's looking at is the guys who's doing the PCIs for the heart, they're the guys that have everybody around their poster. At the same time, there was a guy in Paris named Cribier that was working along the same things. And when Cribier tried to get this done, everybody told him this is going to be a complete failure. This is the stupidest idea we've ever heard. There's no real animal experience that we can do. We're never, ever going to get this done. And he said it was really depressing because nobody wanted to support this. But from 1989, when Henning first did this, to 2002, when Cribier did the very first patient on a guy that nobody would touch, And this is actually in the cath lab where you see him talking to the guy right after it's done. And then 2011, that's actually Henning Anderson with a patient that just had a TAVR. Patient is his dad. So it's kind of a nice little story. Now, the other side of that is that Cribier got the first paper. So I know you feel really sorry for Henning because he worked so hard and Cribier got the paper, but he has the patent. So if you get your choice of between the paper or the patent, always take the patent. That's rule number one from this talk. So this is a little animation of one of the kind of valves. This is called the core valve, and it's got a nitinol frame which is self-expanding. It's a memory metal, and it's got a porcine or pig pericardial valve in it. And as we load it into a sheath, as we pull the sheath back, this thing just expands out and pushes your valve out of the way. Now, in the newer generations, not only can we expand it slowly, but we can actually recapture it and reposition it. So it's becoming even easier to use. And from an engineering standpoint, there's three basic kinds of valves. There's this self-expanding valve that expands on its own and pushes the valve out of the way. There's valves that have a metal frame that's like stainless steel, cobalt chromium, that we mount on a balloon and you blow up the balloon. It's a one-shot deal. And then there's others that are mechanically expandable in a variety of ways, where you get to expand them yourself. And from an engineering standpoint, they're all interesting, but we're going to talk about TAVRs in general. Now, the TAVR trials in the U.S. have provided us with the best data on cardiac valve disease that exists in the world. So this upper left-hand is what was called the Partner B trial, and it was a randomized trial for TAVR versus best medical therapy. And this is over 5 years, and you can see it every year there's a 20% survival advantage for TAVR. When you get to 5 years, you notice the mortality is pretty high in the medical arm. And in fact, there's only one patient in that group that's still alive that has not crossed over to either get a TAVR or surgical aortic valve replacement. And that patient's had 3 balloon aortic valvuloplasties. So it's a bad thing to have. The lower one is the core valve trial, the one that I designed and was involved in. And we wanted to randomize against medical therapy just like the Partner. By the time Partner came out, it was clear that randomizing against medical therapy was unethical. So we basically used the 95% lower survival limits and said we had to beat that, and we beat it handily. So they got approved. These are the high-risk trials. These is when we actually took TAVR and randomized them against surgery in high-risk patients. So really good data, randomized trial. The upper one is what's called Partner A. It was for the SAPIEN valve. And if you notice, over 5 years, there's no difference in survival. Now remember, this is a much less invasive procedure. I don't have to be better than surgery. I just have to be as good as surgery. Now the lower one's the core valve trial, the one, again, that I was involved in. And actually at 1 year, we had statistically superior survival to surgery. For those of us in the field, that was a wow. There's never been an interventional device that's done better than surgery for survival, ever. Now, it was a little controversial, first because it's every time we'd ever seen in the world, and everybody said, well, maybe it's a fluke. And the statistics we use a hierarchical non-inferiority that only if we passed that, we'd go to superiority, so we only had to use a one-tail alpha, and the statistician people went crazy, and they said, well, this doesn't really count. And so I remember I got to present the 2-year data at the ACC, and just before I presented it, I was in a meeting, and John Webb from Vancouver, one of the big giants in the field, was talking about this, and he said, and the supposed superiority of core valve. And I said, oh, John, just wait, come to my talk here in a couple hours. Because at 2 years using a standard 2-tail alpha, we were still superior. By 3 years, we've lost superiority because we have fewer numbers, but we still have a delta of 6.2. So what line do you want your mom on? The blue line or the yellow line? Well, you want your mom on the yellow line. Not only that, but if you look at all-cause mortality or stroke, which is what these older patients want because they're scared to death of stroke, they want to be alive without a stroke, statistically superior at every time point for TAVR over SAVR. All stroke, when we did the Partner A trial, which was the upper left that I showed you, one of the interesting things is that the stroke rate in TAVR was twice that of surgery. It was 5 versus 2.5%. So when I ran the high risk for core valve, I could always tell the people who wanted TAVR is, well, the stroke rate's twice as high in the other one. But now we ran this one, and it's statistically less in core valve. In every trial since that, it's been the same or less than surgery. So that was a big concern early, but it's kind of gone away. And if you look at major adverse cardiovascular and cerebral vascular events, the MIs, the strokes, the things that we really worry about, statistically less at every time point for TAVR over SAVR. So it's kind of starting to look pretty good. If you look at the other 3-year endpoints, one thing that I've seen in every trial that's become an ongoing theme is there's more life-threatening bleeding and transfusion, more acute kidney injury, and more atrial fibrillation in the surgery group. So why is that important? Who cares? Well, it's important because all these have an early hazard risk of death and an ongoing hazard risk of death. It doesn't go away right away. It stays with you. And we have more major vascular complications in TAVR, but as the engineering has gotten better and the delivery sheaths have gotten smaller, those have gone further and further down. NYH classes, basically the patient's telling you how well they feel. They all feel better, both for surgery and TAVR. Why? Because they both get rid of aortic stenosis. The interesting thing, though, is that TAVR actually was statistically better than surgery for flow characteristics on echo. So the top line is the effective orifice area, so you want it to be as high, you want as big of orifice as you can. And the bottom line is the mean gradient, you want it as low as you can. And you notice that TAVR beats surgery on both things, which is amazing that somebody can take a catheter and do better than I can do. And to be a surgeon in this trial, you had to have at least 5 years of aortic valve experience. You had to show that you were doing high-risk aortic valve, and you could do any surgery, any aortic valve you wanted. So surgeons were free to try to beat TAVR in any way they could, and they lost. Aortic regurgitation, surgery still does better. Why? Because I cut the leaflets out, I clean up the calcium, I sew the valve in there. But that's something that's an engineering issue. If we look at kind of a force plot of subgroup analysis, it didn't matter if you were older or younger, male or female, bigger or little, good EF, bad EF, diabetes, no diabetes, TAVR was favored. It didn't matter if you had a previous CAB or not, previous peripheral vascular disease or not, hypertension or not, or an STS above or below 7, TAVR was favored. Now the last one, STS above or below 7, STS is Society of Thoracic Surgery predicted risk and mortality score. It's something we've built from a database of 3 million people in the country. You put your factors in, it tells you what your risk of death and what your risk of morbidity from the procedure should be. And I thought, well, let's just take the people with lower STSs, since they may be less sick, and the less sick you are, the harder it is for TAVR to compete against surgery. But what we found was even in the lower STSs, we had statistically significant survival for TAVR over SAVR. We also worry about, well, do these valves wear out? So let's look at people that have a rise of 50% or more of their mean gradient, showing the valves starting to wear out. And actually there were more in surgery than there were in TAVR, even though that this is already biased in favor of surgery because you're starting with a higher mean gradient, which means to get to 50%, you gotta go more. Now this is a really interesting study we did, because I thought as surgeons we would win, or at least be at least best non-inferior against TAVR. When TAVR was statistically superior to us, I thought, I can't believe it. So I went back and I looked at every single death in the TAVR arm and every single death in the surgical arm and assigned reasons of death and assigned an instantaneous hazard risk of death at every time point. And divided these time points into the early 0 to 30 days, 1 to 4 months, and then the constant, which actually stays flat all the way out to 3 years. And what we found is in the early phase, those are mainly procedural issues. In the yellow curve, the TAVR curve has fallen way down, because remember, when we started in the US, Dr. Kleiman and I did our first TAVR together here in this trial, whereas I'd been doing heart surgery for 25 years. So that procedural thing on day 1 has fallen way down, not 0, but way down. And then what happens, they came down together at 30 days, and then they separated between one month and 4 months, and they came back together again. Why is that? Well, that's because these older, sicker people would survive their 30 days and would send them off to LTAC, and they just never got well. They just died in LTAC. It took about 4 months to really get over the insult to surgery. Once you got over the insult to surgery, your survival has to do with how well we relieved your aortic stenosis and how sick you were to begin with, and that's constant. So it's interesting, and 1 to 4 months is the only time period where the survival was actually statistically superior for TAVR over surgery, but it was enough to tilt the entire curve. So if we want to talk about doing TAVR versus aortic valve replacement for people that are in lesser risk than extreme, people that I could operate on, they'd have to be as good or better in mortality. They are, you saw that. As good or better in hemodynamics. They are, you saw that. Quality of life, I didn't really give you the true quality of life. In these trials, we used the Kansas City Cardiomyopathy Score, the KCCQ. We used a summary. In the KCCQ, a 5-point increase is a small increase, a 10 points a moderate increase, a 20 points a huge increase, and both for TAVR and SAVR, the increase was 27.5 points. Now the difference was, TAVR went up right away. At 1 month it was already there and stayed there. Surgery, it took 6 months to get up there. But by 1 year they're the same. Why? Because when we cut on you, you hurt for a while. Your quality of life doesn't return right away. Patient acceptance, I didn't provide you any data on patient acceptance. Everybody wants a TAVR. People walk in my office and say, Dr. Reardon, I've seen the internet, I need a TAVR, and I have to tell them, I'm sorry you got coronary disease, you need a bypass. No, I want a TAVR. It looks so good. Everybody wants a TAVR. Morbidity, still paravalvular leak and pacemakers, there's some morbidity. Stroke, which we worried about early on, I think we've solved. Durability, we don't know about durability. We have to have longer term data to know about durability. So right now, TAVR is a 2A or a reasonable alternative to surgery in high-risk patients. I would argue with the data we have now, it is a treatment of choice for high-risk patients. If my mother was 85 and somebody wanted to operate on them, I would shoot them now, because we have better statistics. So how about lower risk data? Well, the STS, what we talked about, the STS risk of mortality, you can see it's falling over time. It's left to right is temporal. We had some studies out of Europe where they propensity matched people, just to give us an idea, and in the propensity matched intermediate risk, there was no difference in mortality. There's some very brave guys up in the Nordic country ran what was called the Notion trial. It started way back in 2009. They're going to have a composite endpoint of death, stroke, or myocardial infarction. It's a pretty small study. The Nordic countries aren't all that big. And what they found is in the composite endpoint, it didn't reach statistical significance, but it was certainly numerically less for TAVR versus SAVR for all comers over 70, no matter how healthy they were. Now, if you quadrupled the number in this trial, that probably would have reached statistical significance. And if you look at the individual endpoints, all-cause death, all stroke, or myocardial infarction, numerically less for TAVR. Again, the statisticians will tell you that these are the same lines, but I tell you, I'd like my mama on that blue line. And again, bleeding, acute kidney injury, and atrial fibrillation, more common in surgery. Every trial you look at, as surgeons, I look at this as surgeons, if we want to do better, these are the things we have to fix. Now, there are two trials in intermediate risk patients. One's called the Partner 2A, and one's called Certavi. Partner 2A was intermediate risk, where you would either be a transfemoral or non-transfemoral, transapical, and then beyond that, you got randomized to surgery or TAVR. It was with the second generation valve, again, a cobalt chromium frame with a bovine pericardial valve and a slightly smaller delivery system. And it's going to have a non-hierarchical all-cause mortality or disabling stroke at 2 years. And they're going to have some pre-specified transfemoral groups to look at. Over 2,000 patients randomized. These are big trials. These are really robust trials with really robust follow-up, almost 100%. These are older patients. You can see they're 81 years old. You look at the STS, it's 5.8. I didn't show you the STS for Partner. Partner was over 11, and for the core valve, it was 7.5. Now we're down to 5.8. So we're moving down the scale. They have all the comorbidities that we normally see in these patients. These are fairly sick patients, even in intermediate risk. They all have severe aortic stenosis to begin with. So what are the differences? Well, if you do a TAVR, your anesthesia time is less and your procedure time is less. We can do these a lot faster than surgery. And your ICU time is less and your length of stay time is less. Now, this is pretty old data because we personally don't send anybody to the ICU unless there's a problem. You go to the recovery room and go up to the floor. So in general, our ICU time is 0 in these days, but we're looking at older data. So how about the primary endpoint of all-cause mortality or disabling stroke? Well, TAVR was numerically less than surgery for the entire trial. Not statistically significant, but numerically less. But if you do the non-inferiority test, what you find is you have a relative risk ratio of 0.92. The upper sided is 1.09, which easily gives you non-inferiority at 0.001. Now that's hierarchical. You pass that. We can look at the all-cause mortality or disabling stroke at the intent to treat. We can look at the force plot. Now, a little bit different than core valve. There were two things that actually favored surgery. One was transapical approach, where I actually make an incision and poke the valve through your heart. You can see why that might not be all that great. And really good ventricles. If you look at the primary endpoint, all-cause mortality as the intent to treat for transfemoral, which was 80% of the trial, it's trending towards favoring TAVR. If you look at the as-treated group, transfemoral, it's actually superior for TAVR. So in this pre-specified analysis, you now have another group that's superior over surgery, but now in the intermediate risk group. And if you look at the all-cause death at 30 days for TAVR, it's 3.9 and surgery is 4.1. Now remember, the STS was about 5.5. So that gives you an observed expected ratio for surgery about 0.7 or 0.71. 3.9 gives you an OD ratio of maybe 0.68, 0.65. So again, they're doing, these surgeons did good work, but the TAVR people had less death. And if you look at all the other stuff like rehospitalization, all of them are pretty much the same except for what? Life-threatening bleeding, acute kidney injury, and atrial fibrillation. The major vascular complications, remember it was about 9 and 2, now it's down to 7.9 and 5. They're coming together. So TAVR, the things we have with TAVR are getting better, the other ones are worse. New York Heart, again, this is what patients tell you, yeah, they all feel better, unless they had something else making them sick, but both these get rid of the aortic stenosis. And this is the orifice area, this is the upper curve you saw before. You want to be higher on this, and TAVR is higher than surgery. So here's another valve that actually produces better hemodynamic results than surgery. Still more leak, but the leaks are coming down and getting closer to surgery. If you had a moderate to severe paravalvular leak, it affected your mortality. Not a surprise, it leaves a hemodynamic load on the heart. The SIR-TAVI data will be presented in 2017. I'm either going to present that at the ACC or TCT, depending on how quickly we get the data together. I get my first look at the data December 18th. Woo, let's go. December 18th. I can't wait to get there. Then they did what's called the S3 non-randomized trial. This is their newer valve. They had a little skirt on it to help prevent leakage. And what they were going to do is they were going to do a non-randomized intermediate risk, and they were going to do it against a pre-specified propensity match group from the Partner 2A trial. And they were added to their non-hierarchical composite all-cause mortality, all-stroke, moderate or greater paravalvular leak. Again, these are older patients. They're still almost 82 years old. Median STS for surgery from the propensity match to the previous trial, 5.4 to this 5.2, so it's statistically lower. Not surprising, we're operating on less sick people as we go on. But if we look at the primary endpoint for non-inferiority, it easily makes non-inferiority. If we then go back and do a superiority, once that we've passed out a hierarchical test for the composite, it easily makes superiority. If you break them out to the individual, mortality favors TAVR, stroke favors TAVR, and the only thing that favors surgery is paravalvular leak. Now this is an interesting slide. Look at the 30-day death in the TAVR group, 1.1, in surgery 4.0. Remember the STSs for surgery was 5.4 and the other one was like 5.2? So surgeons did a good job. They have an OD ratio of 0.71, but the TAVR, OD ratio of 0.2. I mean, that's amazingly low death rates. Now, if you go to 1 year, you notice that they spread a little bit more, and that's probably because the surgical group, even though propensity match is a little bit sicker, if they were the same group, you'd expect that to still be about a 3-point spread. But if you're a sicker group of patients, you're going to have more die at 1 year. So it's probably not the best matching, but still this data is moving us along. If you look at the unadjusted time to event for all-cause mortality or stroke, again, I wouldn't make statistics out of this, but certainly lower for the TAVR than surgery. If you look at all-cause mortality, lower for TAVR than surgery. 1 year mortality, 7.4%. That's really good. It's hard for surgeons to beat that. All stroke, lower for TAVR than surgery. So we're starting to see a trend moving towards this. And again, what gets you in trouble? Sorry, I didn't mark it on this one. Acute kidney injury, life-threatening bleeding, and atrial fibrillation, more common in surgery. So when I talk to my surgical colleagues, if we want to do better, if we don't solve these, we're going to have trouble beating TAVR. Now look at the moderate severe paravalvular leak rate, which used to be about 10%, it's now 1.5%. So we're very quickly improving this for hemodynamics. So for intermediate risk, mortality, same or better. Hemodynamics, same or better. Quality of life, again, same quality of life. It all gets rid of aortic stenosis as well. Same KCCQ scores show great quality of life. Patient acceptance, even the intermediate risk people don't want to be operated on. Nobody wants to be operated on. The morbidity is getting less as we go along, and durability we still don't know. So why is that important? Well, high risk, which is about 6.2% of the people out there, has been improved. Intermediate risk, which is about 13.9% of the people, have been improved. That leaves us with 80% out there, and we're running the low-risk trials right now. So these are really big trials. And there's 2 low-risk randomized trials. One is the Edwards Partner 3 trial that's being run by Mike Mack as a surgeon in Dallas and Marty Leon. And there's the Core Valve Evolute low-risk trial that's being run by Jeff Popman at Beth Israel and myself. And we're going to randomize low-risk patients, and we're also going to do what's called a 4D CT sub-study, which is going to be very interesting, look at leaflet mobility. And in England, a good friend of mine, Neil Motor, is running an all-comers trial, randomized trial in England. So we're going to get some really good data, even in low risk. But these TAVR trials have really provided us with the best data on the treatment of aortic cardiac valve disease ever assembled. If you go back to 2004, the amount of Class A data in our guidelines, where it's really based on more than one randomized study, was less than 1%. Less than 1%. I remember when somebody commented about Mehmet Oz on his show, was talking about all these crazy green tea things, and they said he's talking about all this stuff without data. And somebody pulled out our guidelines and said, you know what? His data is pretty much as good as what we got out there, because most of us is level C evidence. So you remember what level C evidence, that's basically expert opinion. I mean, my example of expert opinion was back early on when Copernicus said that the Earth was not the center of the universe, that we actually went around the sun, and Pope Pius IX said, well, that's blasphemy. So he called all his bishops in and they said, guys, this guy says that we're not the center, the sun's the center. What do you think about that? Because I think we're the center. And they all said, we agree with you. So the church put out a class 1 recommendation, the Earth is in the center, level of evidence C. So, level of evidence C is really not that strong, but a lot of what we do in medicine is built on that. Here we've built some really good level of evidence A to go from. Now, currently we use a variety of valves. We use the Sapien S3. This is the metal frame, cobalt chromium, so it has to be expanded with a balloon. We use the Evolut R, which is a nitinol frame, which is a memory frame, which expands out itself. They now are recapturable and repositionable. We used the Lotus valve. I ran the Reprise 3 trial, which was the high-risk trial for Lotus, and we just submitted the intermediate risk trial for Lotus. So I have the opportunity to run that too. And the difference is it's nitinol, but there's these little buckles and posts at the top and the bottom connected by a wire, and you let it expand out to where the nitinol goes, and then you twist the handle and it pulls this buckle and post together until they lock. As you shorten something, what happens? It widens out. And so this is a mechanically expandable valve, and it's never obstructed, so you can dial it out as slow as you want to and get it exactly where you want it in place and look at it and decide if you like it. If you like it, you let it go. If you don't like it, you can unlock it and move it, or even put it in a different valve. So it's getting to be much more like a surgical valve. There's the direct flow valve that we also do. It's a unique little valve. These are hollow Dacron tubes, and it has a bovine pericardial valve in it. And what happens is you blow up the lower one, and then inside the ventricle, and you pull it back until it locks at the annulus, and then you blow up the upper one, which pushes the valve out of the way. And then if you like it, there's a little machine that takes the saline contrast out and replaces it with a polymer that sets up. If you don't like it, you can just deflate it and move it again. So it's infinitely repositionable. And then Portico is another self-expanding valve that we're testing here. So paravalvular leak, as we talked about, that's one of the Achilles heels, so we don't have much paravalvular leak in surgery. So this is direct flow, looking at the paravalvular leak at 1 month was 1.7%. By 1 year, it was 0. Looks like a surgical valve. The Reprise trial from Europe, and we'll be presenting this data in the US soon for the US, but by 1 year, no moderate to severe paravalvular leak, only 11.4% mild. You'd accept this in a surgical valve. Sapien S3, it was about a little under 4%, and even that's coming down as people learn how to use this valve better. The Evolut valve, it was less than 4%. We're testing a new valve here I'll mention in a minute called the Evolut 2.0 or Pro. But this is what we've seen from the beginning trials to now with paravalvular leak. This is all in about a decade. This advance has been in a decade. So 1 decade from now, I expect these to look just like surgical valves. And this is the 1 year paravalvular leak rate and what's happened in just a decade. Evolut 2.0 is the Evolut valve, and they actually wrapped a pericardial skirt around it to help seal it up. And we're part of that trial, and so far, in the ones we've put in, we've seen nothing more than trace PVL, something that we'd be happy with in surgical valves. So I think that paravalvular leak will be largely solved and similar to surgical valves with engineering design and improvements. I have very little worry that we're going to solve this. Now, the real question is going to be durability. How long are these valves going to last? For those of us who've been doing surgery a long time, we understand that you can't really predict that from what you see to begin with. There was a valve that I was very interested in called the Toronto valve, which is a stentless porcine valve, and it let you use the native aortic root in the sinuses, and it looked great. I thought it was going to change the face of valve surgery until you got out to about 8 years, and it just started failing at a very high rate. It's now off the market. The other thing about durability is that when I talk to my patients about getting a tissue valve, they're all worried because somebody's told them only half of them last 10 years. And what I have to tell them is that there's 2 things I know about getting older that apply to all of us. One is for every year you live, you have 1 less year left on this planet. That's just how we are. The odds of me living 20 years are not as good as the odds of my 39-year-old daughter living 20 years. It's how we're designed. The other thing about getting older is the older you are when I put a tissue valve in you, the slower it degenerates. Nobody really knows why. My personal theory is that it's a very low-grade foreign body immune reaction, and the older we get, the less robust our immune system is. And so the valve just degenerates at a slower rate. So how old were these people that we put these valves in? They're 84 years old. They're not going to live long enough to find out if these valves degenerate. First of all, valves don't degenerate in 84-year-olds because they're so old, number one. And number two, they don't live long enough for us to find out. So we're not going to, unless there's an early durability signal, we're not going to get it from these trials. Now this was presented at EuroPCR in Paris by a friend of mine, Danny DeVere from Vancouver. And what Danny did is he took these cases from Vancouver and from Rouen, France, where they really started this, that were about 10 years old. And he looked at structural valve deterioration, and he showed this chart, and it looked like at 5 years it started falling off the cliff. And of course, all the surgeons in the audience cheered, yay, our valves are gonna do better, this is gonna go away. And my phone started ringing with reporters calling me, oh my God, we wanna write an article about this, what's going on? I said, well, what was Danny's definition of structural valve deterioration? Because in surgery, when we write about it, our definition is you either went back to surgery or you have an echo that shows the problems that would lead to structural valve deterioration, such as a gradient of 40 or severe AI. And a lot of people that older don't go to surgery because they refuse to be operated on. Well, what Danny said is he said, listen, anybody that didn't have a gradient of more than 20 at a month that developed one is structural valve deterioration. Anybody that didn't have moderate or worse paravalvular leak at a month that developed it was structural valve deterioration. Well, the problem is if you apply this to surgical valves, you're going to get a huge number of them failing. Why? Because unfortunately, we often operate on smaller women or people with little anuses. We put a valve in when it's not the greatest result, and we have a mean gradient of 16, 17, 18 coming out of surgery. But they're better than they were. They started at 45, and they're asymptomatic. And then we see them back at a year, and their gradient is 24, but they're asymptomatic. So what do we do about that? Well, we pat them on the shoulder and tell them, sure, you're fine, go home, because nobody wants to hear about a reoperation. And so what happened was Danny used this really stringent criteria rather than people that are going back to surgery. And in fact, if we did this for surgical valves, you'd find that the curve is actually steeper than this, but this caused a lot of consternation. So I went back and looked at the high-risk group that we randomized against surgery, and I looked at a mean increase of greater than 50% between 1 month and 3 years. And if you notice, TAVR was statistically better than surgery, even though surgery started higher, so the definition to get to 50% was worse. And by 3 years, the mean gradient of the group is 18.2. How many of those are going to be above 20 and meet Danny's criteria? So that got everybody all jazzed up, but I think once we put it in context, everybody started to calm down. Now, why did everybody get jazzed up? Because this is a multi-billion-dollar business. And you know, if this was going to fail, people were going to lose billions of dollars. Now, we also looked in the high-risk trial, we looked at people that started with normal EF, and we looked at stroke volume, how much your heart kicks out every time it beats. And what we noticed was, for surgery, your stroke volume went down. It took about 6 months to recover. And that didn't happen for TAVR. We also looked at RV function. We noticed that there was a lot more RV, right ventricular dysfunction, in surgery than there was in TAVR. Well, why would that be? Well, the reason is that surgery hurts the heart. Why does surgery hurt the heart? Surgery hurts the heart because I have to put a clamp on it, and I inject this freezing 4-degree centigrade cardioplegia to stop your heart in a metabolically inactive phase. Now, it's better than letting your heart beat, but freezing the heart is just not a good thing, whereas we don't do that in TAVR. And we're not going to quit doing this between now and the future, because that's the only way we can get inside the heart. We got to stop the heart. And so surgery hurts the heart for at least 6 months, and that's going to go on into the future. We've already talked about this. I think as we move into lower risk, what we're going to find is that 1 to 4 month is going to start coming together. But what if it comes all the way down to where TAVR is? Does that matter? No, of course it doesn't matter, because all you need to be is as good as surgery. And as we run the low risk trials and we try to do a non-inferiority trial, what happens when you run trials that have less events? Non-inferiority is a lot easier to achieve. In fact, to me, it's a setup for TAVR to at least win non-inferiority. So more predictions for the future of where surgical valves can go, and that surgical aortic valve replacement's a mature technique. It's been going on for 60 years. I did my first aortic valve replacement in 1983. So I've been doing it for a while, as have a lot of surgeons. TAVR is young, is likely to undergo substantial improvements, and already has undergone substantial improvement. I did my first TAVR, as did Dr. Kleiman, in February of 2011. And look at what's happened just since then. The technical disasters that we see in TAVR have already decreased and will decrease further as we get better systems and learn it better. Now, the other thing that's really interesting is surgery is technique driven. I don't know if any of you have read Malcolm Gladwell's book, The Tipping Point, and he talks about how it takes 10,000 hours to be an expert in something. For technical things, that's true. You know, you can't become an expert at playing the piano by, playing it a little bit. You got to play it a lot. Whereas TAVR is technology driven. Technology is a little easier to learn and diffuse. So if I take somebody that has a descending thoracic aortic aneurysm but has a good neck at each end, replacing that surgically takes some technological expertise. Even though to me it's a relatively easy operation, if you haven't done it, you're not going to do very well. But Dr. Lumsden and I can take you in there and say, listen, put this graft right here, get it here. Okay, there you go. Pull the string, deploy the graft. Look, you did it, you fixed it. What that means is that there are a lot of places in this country that don't have expert surgeons that can do aortic valve replacement. In fact, the average surgeon in the U.S. does how many aortic valve replacements? Anybody want to guess? What does the average U.S. surgeon do for aortic valve replacement? A little more than 5, it's 8. Mitral valve repairs is 5, aortic valve repair 8. Do you really want your mom to operate on somebody that does 8 of these a year? Probably not. The difference is that TAVR is something that can be taught better, and so if you're living out in Wyoming, you're much more likely to get somebody who can really do this than if you have to have surgery. So it'll enjoy a much wider adoption. We used to ask which cases are bad for surgical aortic valve replacement, and then we do a TAVR. Now we're starting to ask which ones are bad for TAVR anatomically. Maybe we should consider surgery. It's really been a paradigm shift. Now we all started when we had these risk boxes, and everybody realized there's no box. It's a rainbow blend as you go across from low risk to extreme risk. And what we also know is that there's 2 bars, one of which we don't go beyond. If you're so sick that I'm not going to make you better, I can always get rid of your aortic stenosis, always. But if you're dying of bad lungs, you're still going to die of your bad lungs. And so there's a point where we can make your aortic stenosis better, but not make you better. Treatment then is futile. So there's a line beyond which we don't go. And there's a line below which we haven't gone because we've been restricted. Now I really should move this down to intermediate risk now that that's been allowed. Both these lines are moving to the left, even the futile line. We're doing less and less futile patients. And it's really going to center around durability. Because if durability is found, I have no doubt that anybody that's a candidate for a tissue valve is going to be offered a TAVR unless they're anatomically not a candidate for it. Now, why is that important? Well, this is what's happening in the next 10 years. TAVR should go up about 9 or 10 times. I mean, it's going to be huge. This is what happened when we started our valve clinic in 2009. We got passed over for the partner trial, mainly because everybody in Houston was fighting with everybody else and we didn't have the structure. So we need to build the structure to track this trial. We need to build a heart team. We need to build a valve clinic. And this is the new patients up through 2014. 2015 new patients were 205. 2016 we're not there, but it's probably about 220. This is new consults. This is established patients. We saw over 1,000 people last year. We'll see over 1,000 people this year. This little clinic, which basically started in my clinic because I donated the space, has outgrown what we can do. If this was a business, you could arbitrage this thing into infinity. This is a huge growth rate. And so far it hasn't gone away. This is our TAVR growth. I just have this to 2014, but I can tell you in 2015 we did 225. 2016 we're probably about 240. We've done almost 1,000 here in total. And the red is surgical aortic valve replacements. So what's interesting about this picture? What's interesting about this, if you notice between 2010 and 2011, we added over 100 open aortic valves because they came into our valve clinic looking for TAVR and they just got surgery. And that stayed every year through 2014. In fact, in 2016 is the first year we're starting to see a little bit of a decrease. We're finally eating into it. And we will eat into it some, but it's not going to go away. There are still people that are going to have endocarditis, root problems, too young for this. So surgery is still going to be here, but it's not going to go completely away. Now, I was hoping that if I had a little bit of time, I could take you into kind of the next frontier. TAVR's great. It's been good for us. It's been good for our patients. It's been a mountain we've climbed. And as Dr. Lumsden often says, often people build these mountains and they try to keep everybody off. No, come on up my mountain. Because while you're climbing my mountain and not paying attention, I'm going to go to the mitral valve. And the mitral valve probably has 8 to 10 times as many people out there with disease than the aortic valve. So it's even a bigger field to play in. Now, there are some problems. If you look at the aortic valve, it's pretty straightforward. You just have to make it bigger, and it's easy to figure out how you're going to do your trial, because if I don't fix you, you die. So that's an easy thing. If you live, it's a good therapy. This is the mitral valve. It's a little more complex. I used to show, when I had to quit showing it because it got me in trouble with my wife, but there was a box with one switch, and it was the aortic valve, and a box with like 97 switches was the mitral valve. But my wife knew I got that off the internet because the one with one switch was a man, and the one with 50 switches was a woman, and my wife said, you can't show that anymore. So I said, I've got to go the highway. But it's really very complex. And the problem is that not only is it the anatomy, but there's 2 different diseases. There's primary mitral regurgitation where the valve itself breaks, and there's functional or secondary MR where the valve is fine, but the heart breaks around it. heart failure. There's been a lot of different valves tried out in humans. And there was this explosion of acquisition in 2015 where all these companies were acquired. Over $2 billion were spent acquiring mitral valve companies. $2 billion. Now, the next question is, well, they must have pretty good data to base this on, right? You know how many mitral valve replacement cases have been done in the entire world to base this $2 billion on? Less than 100. Now, I'm not a great math guy, but if you divide less than 100 into 2 billion, you find that they paid a whole lot per case. But that shows you the enthusiasm for this. Now, here we're involved with a valve from a company named Medtronic. It's called the Intrepid Valve. And what it has is it's got a two-piece valve. It has an outer conformable piece that's going to lock to the heart and an inner valve that is hooked to this but can move somewhat independently from this. It looks almost like a cork when you put it in there because the atrium is up there and the pressure is up this way, but you see how it slants outward, so it kind of wedges itself in. And what happens is you deploy it in, you deploy this brim, you retract it, you let it go, and you expand it in position. If you like it, then you let it go. So this is the case we did. This is a functional mitral regurgitation, and you notice how the valve is saying, help me, help me, help me. You know, you can't, it doesn't quite meet in the middle, but the leaflets are moving fine. So what you do is you do a little anterior thoracotomy, and then this is me poking at the heart and Steve Little looking at an echo, trying to line up where I'm going to put this into the heart. So we just do this very high-tech called finger poke. You know, some of us use our thumb, some use this finger. You know, if you're really delicate, use your little finger, but highly technical. And it's all done by echo, and as a surgeon, I'm doing this. It's not fluoro. This is all done by echo, which is interesting because, you know, imaging is moving the world right now, and I'm having to learn this new imaging because this isn't completely done by echo. So Steve Little's doing the TEE, they're lining it up, I'm retracting it into position. Once I get it down in the position with rapid pacing, see the heart's just kind of wiggling. I have 3 people that I need a go, no-go from. The engineer from the company, Steve Little, and myself. And once we get it there, there's no equivocating. If you don't know, you just tell me no, and we turn the pacer off and I move it back and I start again. And once we got to this point, it looked good, and I got to go, 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 and then we released the thing, and now you have this new valve. And this is what the 3D looks like. You can see there's basically a couple red cells coming through, but nothing. And this is what it looks like on ventriculogram. Nothing's leaking. You can also see it's pretty big. It's like putting a beer can in the heart. Now, this guy actually came to see me 2 weeks after his surgery because somebody had forgotten to take his little black silk stitch out where he had his drain, so he came to see me, and we took the stitch out. And he was downstairs, and he saw Dr. Kleiman, and of course he ran over to give Dr. Kleiman a hug because Dr. Kleiman was his primary cardiologist. And Neil told me he didn't recognize the guy because when the guy was in the hospital, he was in the hospital on IV milrinone, and now he's running around and back to normal. So it really is, quite amazing. Some of the things we're going to get to do. This is the 3D before. This is the 3D after. You walk in with this, and although we do this with general anesthesia and a small anterior thoracotomy, you wake you up at the end. We do send this guy to the ICU, but eventually, like TAVR, they'll just go up to the floor. And we're already working on the next model that's not going to go into the apex of the heart. It's going to go through the vein in your leg, across the septum, and over, which means that we can do this under local, and that we can walk you out of the hybrid room and walk you up to your room. So I think we have a very exciting future. I think the things that we're going to do in the next 10 years are going to dazzle and amaze everybody. But I thank you for your attention. I'm happy to answer any questions.
Thank you.